Next, I'd like to welcome Dr. Electra Paskett. She is Professor of Cancer Research and Director of the Division of Cancer Prevention and Control at Ohio State University. She's also, as a result of her funded research, an internationally recognized cancer epidemiologist. Please welcome Dr. Paskett.
Good morning, and thank you very much for the kind invitation to talk about this very important topic. I've appreciated the speakers who have preceded me, and I think you're going to hear some very similar themes in my presentation, but we're really going to focus on the U.S. and talk about the urban and rural populations that we mainly work with. So what I'm going to talk about, first of all, is talk about the populations of interest that I focus on in terms of challenges faced, including the African American population in Columbus, Appalachian, and Amish. I'm also going to dig into my past setting where I was working in North Carolina for some of these examples. I'm going to give you 5 lessons learned that talk about strategies to address cancer prevention and control in these populations, and then review what I think as remaining challenges. So first of all, I'll talk a little bit about the population. So in inner city, I'm going to talk about examples in Winston-Salem, North Carolina, specifically focusing on low-income housing communities. The population frequented one federally qualified health center, and it was an overwhelmingly predominant African-American population. In Columbus, we have many minority groups. African-American is our largest. We have a growing Hispanic population, Somali population, as well as Asian population. The health care is delivered by health departments, federally qualified health centers, and free clinics. Just for your information, in the United States, the majority of the U.S. population does live in urban areas, and the problems in urban areas are high rates of poverty, environmental exposures, high crime, poor housing, discrimination, and what is referred to as food deserts, which we'll talk a little bit more in a minute. There are increased concentrations of minority populations in the urban inner city, and the healthcare organizations there often struggle to meet the growing needs and demands due to different languages, lack of insurance, the social issues, as well as some of the cultural differences. Our rural area is Appalachian, Ohio. This is a 32-county area of Ohio designated there in the red. It's part of federally designated Appalachia in the United States. It's mainly white. In Ohio, it's mainly white and low income. It also has many healthcare professional shortage areas. Those are designated also by the federal government. Access to care is a major problem due to cost, quality of care available in those areas, transportation, and trust of the medical system. There is an Amish subpopulation in this area. It is the second largest east of the Mississippi. The Amish have their own unique problems associated with their culture, that they lack, don't use transportation, etc. And I'm going to give you one example of a project we did with the wonderful Amish population. So let's go a little bigger. In the United States, 72% of the U.S. landmass is classified as rural. 19% of the population of the U.S. lives in rural areas, or 46 million people. Rural includes not just rural, but farm areas, mountains, and frontier lands. The populations that are found in these areas, in addition to white and Appalachian, include African American, Hispanic, American Indian, and Alaska Native. Rural populations in general are understudied due to their physical location. It's a lot harder to get there. You can see where Ohio State is to the farthest area in our Appalachian area. It's 3 hours by car. You can't go straight there. My staff always remind me you have to go around. Cost issues and the perceived need. The perceived need is that they don't need to be studied. So that's a barrier we need to address. And this is just one example. This is a study we just published And we found in our research that in Appalachian, Ohio, 24% of women aged 50 to 74 have received a mammogram in the past year. This is not self-report. This is by medical record review. And it's because of barriers to care, lack of insurance, poor health literacy, travel and financial concerns, and the traditional gender roles of taking care of the home and the children are often have to be interrupted by travel to take care of themselves. And as a result, breast cancer is more likely to be diagnosed at a later stage compared to urban women. So let's move on to lessons learned. The first one is that we really need to take the message to the people, but the message has to be developed with input from the people. So I'm going to go back to North Carolina. So we did a study called the Forsyth County Cancer Screening Project, funded by the NCI, and it really focused on increasing breast and cervical cancer screening among poor and minority women in 2 low-income housing communities. We did community-based interventions. We actually bused the women to these locations where they received free screenings. When we started our study, we realized the women didn't even know how to get to the medical clinic to get a mammogram. So the first thing we did was tell them how to get there, what bus route to take, etc. And then once they got there, how do you sign up to get a mammogram? And that was the first thing that we did. When we went out into the community, we delivered messages using what we call lay health advisors or community health workers, and they focused on culture to deliver the message. So hair is very important in the African American women community, so we use that analogy. Religion is also very important, as well as heritage. So all of those messages were included in what we were trying to deliver about health. We used a community advisory board and a provider advisory board to give us input. Sorry, this clicker's a little slow. And we did find that our intervention increased both mammography utilization as well as pap smear utilization in the intervention communities compared to the comparison community. Second lesson, the human touch is the utmost important factor to addressing disparities in care. So I'm going to give you a little example, a follow-up of screening abnormalities, which actually we feel is one of the most important factors in the high rate of cervical cancer mortality among African American women. Mrs. Jones is a 33-year-old African American woman with cervical abnormality on a routine PAP. The OBGYN recommended follow-up with colposcopy in 6 weeks. She has no other health issues, 5-year-old twins. She's college educated, working, a beautiful woman. Mr. Smith, 51-year-old black man, presented with rectal bleeding and pain. His primary care provider recommended colonoscopy as soon as possible. He has a history of mental health issues, no transportation, difficulty understanding instructions, and lives alone. So if I ask you, I do this when I lecture to the medical students, who returned for a follow-up? Who would say Mrs. Jones? Who would say Mr. Smith? A few. Okay. Well, the answer is Mr. Smith. And why did Mr. Smith return? Because he was assigned a navigator. And the navigator coached him many times over the phone on the need to schedule a colonoscopy. Well, I don't have time off work. You can take a sick day. Oh, you can take Monday. Do your exam Monday, prep Sunday. She told him how to take the prep. She actually had to drive him there. He had no family who could take him. And look, he had a polyp, a big polyp. Okay, that was removed and a cancer was prevented. And that's what the human touch does. Okay, third lesson. Cost is still a barrier to care, and it can mask cultural barriers that impact asking for help. So in Appalachia, when we were funded for our Center for Cancer Health Disparities, we did formative work, and the first thing we learned was, we don't talk about cancer. We don't say that word. And cervical cancer especially not. Okay? So how do you then do a program to prevent cervical cancer in this population? You use the community to help you. And in all of our research, we work with community-based coalitions and councils throughout Ohio, Appalachia. So I'm going to tell you the story of Gallia County, where the coalition identified a problem. They said there was a high rate of cervical cancer and lack of accessible resources to actually deal with that. The health department completed 512 PAP tests on the breast and cervical cancer early detection program, and 18 to 22% were abnormal compared to the rate of the U.S. at that time of 3 to 4%. And 31 to 47% of the Gallia County Health Department clients with abnormal PAPs didn't come back for follow-up. That was a significant problem. And actually, they came to me and said, Dr. Paskett, we have 48 women who can't get any provider in the county to see them, and they have an abnormal PAP. So they developed a plan. And I'm not going to go into detail on all the bullets there, because on this next slide, I'm going to tell you what they did. They formed a free clinic in the county to provide colposcopies at no cost for these women. They worked with the health department. The health department donated the space, and their goal was to improve adherence to the follow-up recommendations. We helped them write a grant to the governor's office of Appalachia, and then they had to raise $4,000 to match that grant to buy the colposcope and the biopsy forceps, etc. So they secured a local doctor who donated his time to provide the colposcopies. They've had 54 clinics since they started in 2010. 97 colposcopies performed. 6 women required additional follow-up. But all women are given specific educational brochures and gas vouchers, because that's a huge barrier to get them to come, is the money for gas. And they've continued this clinic through the support of the network. We work in the Appalachian Community Cancer Network. We help them secure 501c3 status, and they can receive future funding as needed to keep this going. That's just a picture of some of our coalitions. Lesson 4, offer with genuine concern and they will come. So this is a wonderful example of one of our new faculty, Dr. Daryl Gray. And this example deals with Inner Columbus. He decided in March that he would do a colon cancer awareness month. He started with Wellness Wednesdays and Walk with a Doc grocery store tour. You can see at your right bottom the docs in the store with folks teaching them about nutrition. We had a chef come to teach how to prepare healthy foods. We had an inflatable colon exhibit. I don't know how many of you have walked through the inflatable colon. It's quite exciting. And we trained medical students and others to give the scripted walkthrough. We also have an IRB-approved research project, so we have the participants do pre- and post-assessments about their knowledge. And at the end, Dr. Gray, he's down there at the bottom with Brutus Buckeye on the right, where he's there and they can talk with a physician. And he has a wonderful YouTube video that's running, which is actually a real colonoscopy being done. And we actually have a person there that can schedule an appointment for them. And then top that off with free screening colonoscopies in the month of March. And this was a whole enterprise by the Division of Gastroenterology. Bottom picture, the gentleman on the left is Dr. Conwell, who's the head of that division. And so we assembled a team that schedules. We have a patient navigator that calls the patient to help schedule, help get them there, help them with the prep, etc. And then we did 50 colonoscopies in the month of March, 174 polyps removed. Almost everybody had a polyp, not all adenomas, and the GIs could not believe how well the prep was. And we had nobody cancel. Everybody came. And it was because we had a navigator who contacted them. So we're repeating this again this year, already planning for March. Place is a barrier. So I'm going to talk a little bit about Vinton County. This is one of our counties in Appalachia. It is classified as a food desert. This is not urban. This is a rural county classified as a food desert. The only full-service grocery store closed, that's down here at the bottom right, MacArthur Food, closed in September 2013. They have no grocery store in the county. This is a little bigger than just Gallia County. 24% of rural households drive more than 10 minutes to any retail food store. But in Vinton County, 100% of those households need to drive more than 25 minutes to the closest retail grocery store. There used to be a Kroger there, and it left a long time ago, and we can't convince any grocery store to come and open in Vinton County. So what did we do? We put a grant in with our extension service, and we got a small grant to teach the people in the community, the city of MacArthur, to first establish a community garden, to learn how to grow container gardens, to encourage healthy eating through programming on producing, preserving, canning, etc. And we really want to increase year-round access to fruits and vegetables among the children by doing this, as well as raise awareness about the role of nutrition in preventing cancer among residents. And so this project just finished this summer, and we hope that this will be long-lasting with them. So let me talk about the challenges that we need to overcome. Well, first of all, in our populations, real-life problems for them require immediate attention versus health. So one of our community advisory board members in the Focus Project was diagnosed with breast cancer and given a prescription for tamoxifen. And she came to us and she said, "This will cost me $90 a month. I'm on a fixed income. Do I pay the $90 a month, or do I pay for food and heat and rent?" This is a huge problem. So we worked with her to get the pharmaceutical company to pay for her prescription. But again, it takes the personal touch, and not everybody's keen to that. We talked about place. Place exerts an influence. I'm sure you've heard the issue of stress and disease and how place gets under the skin. I'm going to show you a little example of that in just a minute. And then geographic isolation factors into access to quality care as well as slow diffusion of new technologies. So this is, again, back to getting under the skin. So in our Appalachian community, I've told you a little about socioeconomic status. So we're at the top box. Socioeconomic status is low, low access to health care. Social support, very poor, causes loneliness. Not good Appalachian self-identity. And self-identity, for example, in Hispanic communities adds a little bit of security. And the coping strategies are very poor. So what do people do? Smoke and drink, risky sexual behavior. The smoking and drinking, as well as the stress, cause depressive symptoms affecting the immune system. The risky sexual behaviors, which they use to cope, leads to increased HPV exposure, HPV infection, and higher rates of cervical cancer. So place does get under the skin. Cultural differences and the role of providers. We know that the most important reason for the uptake of health behaviors is provider recommendations, but they're not always being given. And language and cultural differences are still barriers to care. This is what we're doing in the Amish community. We bring our mammo van there for them, right to them, and they come and get their mammographies there. We also take them in our vans to follow-up care if they need care. Under that, I also listed the cost of outreach not covered. So we did this fabulous program in North Carolina. We handed the book to the health department, who had been our partners through the whole endeavor. "Thank you, sorry, but we don't have the time to do this." The women in the communities cried when they left because they said, "Nobody has ever come to us and done this for us." Sources of information are not always appropriate. So we'll go back to the champion, which the last panel talked about. Respected opinion leaders, for example, in Appalachia, it's nurses and teachers, and they don't always have the correct information, and at least in our communities, they're anti-vaccine. And the national media is often heavily relied upon. So we can all remember 2011, Michelle Bachmann's comments about the vaccine, but I love this one headline here, which is quite telling, okay, now in 2015, how that comment has led to our poor uptake of cervical cancer prevention vaccine. The multi-level model, which you heard by many speakers today, is not widely utilized. And it really needs everybody, from the policymakers and the funders, to be included. And this is our socioecologic model that we developed in the Centers for Population Health and Health Disparities, fondly called the Warnke model. But it basically says, you know, a lot of what has already been said, that health disparities are a cause of multiple levels, from the biology at the bottom all the way up to fundamental causes of social conditions, policies, and institutions. So I want to leave on a happy note, okay? So I'm going to give you an evidence of success. This is a great story. This is a real-life example of what Delaware did in colorectal cancer disparities. They had a plan from the top down, bottom up, to improve colorectal cancer screening rates among African Americans in a statewide colorectal cancer screening program. They had a navigator, a coordinator, reimbursed the underinsured, case management for abnormal results, and they screened. And what they found at the beginning of the program was this gap in screening rates, and by the end of the program in 2010, they eliminated the screening disparity. They found that there was a disparity in stage of diagnosis by African Americans in 2001, and then by 2009, they had shifted stage of diagnosis by 235%. Incidence rates, you can see the gap there on the left that started, and by the end, they had eliminated the incidence disparity. And for mortality, wide gap here on the left when they started the program, and they had just about eliminated the mortality disparity. So mortality decreased by 20%. Delaware is now in the top 15 states of lowest mortality, and how they did it was with universal screening and universal access to treatment. So, in conclusion, low resource areas in the U.S. suffer a disproportionate burden of cancer risk factors, incidence, and mortality. And cultural and socioeconomic factors are related both to place as well as racial and ethnic groups, and they contribute to these disparities. We have found that the interventions that address these disparities are most successful if they include the multi-level factors related as well as the cancer problem in question. But the interventions need buy-in from all levels of the community, from policymakers as well as from the community members. And the strategy will also facilitate culturally appropriate interventions that are accepted, long-lasting, and paid for. So thank you very much for your time.